Morning, everybody. Can you hear me? If you can hear me, then
yes,
we are starting off our grand rounds on the 2nd of June. I have the immense pleasure of welcoming Professor Jan Steffel from Zurich, who's kindly agreed to talk to us and educate us on atrial fibrillation with a specific focus on anticoagulation strategies. As an introduction, Professor Steffel is Vice Chairman and Professor of Cardiology at the University of Hospital Zurich, where he's also Senior Consultant in Invasive Electrophysiology and Implantable Cardiac Devices. He studied medicine in Bonn in Germany, Lausanne in Switzerland, had further training in Boston and Munich, and after graduating medical school in 2003, he went on to do all this training and is on faculty at Zurich. He's an active lecturer with focus on research with over 150 publications in international and national journals. His primary research focus is in the field of anticoagulation for stroke prevention in atrial fibrillation, as well as novel cardiac device technologies such as leadless pacing and the subcutaneous ICD. He's the first author of the 2018 and 2021 EHRA Practical Guide on the Use of NOACs. Professor Steffel is chair of the EHRA Education Committee and is actively involved in a multitude of educational activities. With this brief bio, I would like to welcome Dr. Steffel, and we're going to listen to his talk. Fascinating. I've already had a preview, and I'm sure all of you will be enthralled. Please go ahead.
Well, thank you very much indeed for the very kind introduction. Thank you, first of all, for having me. I already had the pleasure over the last half hour to meet some of the senior staff from your institute, which was equally a great pleasure. And I already mentioned to them, of course, it would have been terrific to be there in person. And even after over a year of the pandemic, I'm not getting tired of saying this. I am looking forward to being back in person and to meeting up again. Until then, I think this is nevertheless a very good way of staying in touch and staying connected, and also be staying connected about these important topics, because ultimately, obviously, of course, our minds are on COVID, but all of our other patients still deserve our attention, and therefore we need to tackle these issues. The atrial fibrillation and stroke prevention in atrial fibrillation in particular, of course, are very important topics. Number one, because it is a devastating consequence of atrial fibrillation, or a devastating complication in these patients. And secondly, because it affects so many of them. I mean, AF obviously is a pandemic in and of itself, and one that's not going to go away within the next, months, hopefully. But that's going to stay, and which will actually only get even bigger as people get older. So although the whole field is complicated and complex, it can be distilled down to some very pragmatic and very good concepts for daily clinical practice. And it's definitely time and effort well invested, because this will be staying with us for the next years, for the next decades to come, and actually become an even bigger issue. Today, we'll focus on the frail and elderly AF patients, primarily because these are amongst the highest risk individuals for everything, for stroke, for bleeding, as well as for undertreatment. And as a result of that, I think it makes sense to take a look at this in a very dedicated manner. Now, these are my disclosures, which includes fees from all manufacturers, from all NOACs. So I will obviously be also giving you a very balanced presentation, also be happy to tackle any questions that you may have afterwards. Now, before we start about this special patient population, I think it makes sense to briefly take one step back and take a look at where we come from. Because frequently in these situations, we feel that we do not have all that much randomized clinical trial evidence available to guide our practice with NOACs in the frail, the elderly, and so on and so forth, high-risk subgroups. But when we take a look at it, what was the evidence for vitamin K antagonists with which we have been treating these patients so far for the last decades? It's not that much. Ultimately, there were 6 trials. This is Bob Hart's meta-analysis here. 6 trials, the old trials that you can see here, that were conducted Warfarin against placebo, that included not even 2,900 participants. But it did indicate quite a substantial risk reduction with Warfarin. And as a matter of fact, Warfarin was the only drug until the NOACs came that actually led to a reduction in mortality. So pretty tough nut to crack, but not a lot of evidence. Not many patients that were included in this. And afterwards, there were no more placebo-controlled trials. So for many populations that today we're asking the questions, are NOACs good? We have to admit that was a question that had never been asked to vitamin K antagonists. And then, of course, came the NOACs, and we've kind of grown used to seeing this slide. This is from my friend Chris Ruff at the TIMI study group in Boston that brought out this trial-based meta-analysis where we can see that ultimately, when we take a look at all NOACs as a class, it's a statistically pretty homogeneous effect, although high dose of dabigatran is pretty far out here in terms of really favoring NOACs. But as a class, it's pretty homogeneous. There's an additional 19% relative risk reduction for stroke. We've kind of grown used to this, but when we think back in 2009, prior to Stuart showing us the data from the RELY trial in Barcelona at the ESC meeting, we would not have, I don't think we would have anticipated these results. I mean, we would have thought that NOACs were probably just as good as Warfarin, maybe a little bit easier, maybe a bit better on the very severe bleeding events, but that it would actually come out even better. I don't think many of us would have anticipated this. And the second thing, of course, was the big surprise was that in terms of the flip side, major bleeding, there wasn't a single NOAC that led to a higher incidence, or at least a statistically significant higher incidence in major bleeding. However, there was some heterogeneity between the trials here, in the sense that high-dose dabigatran and rivaroxaban came out similarly safe, whereas apixaban and edoxaban in their respective trials came out even safer. So also had a reduction in major bleeding events. Of course, we are all aware we need to be very careful in not too much cross-comparing these trials one to another, because obviously these were independently conducted, different drugs, sometimes different inclusion criteria, sometimes also slightly different endpoint definitions. But ultimately, this is how these trials came out. And in terms of evidence, this is huge, because obviously now we're talking about anywhere between 14 and 21,000 patients per trial, right? So a huge evidence base that we are basing our today decisions on. As a result of that, the guidelines have changed. And we'll hear later about the CCS guidelines, which of course you're very much aware of and you're using in daily clinical practice. The European guidelines are not much different in many regards, and neither are the American ones. There's clearly a class 1 recommendation with a level of evidence A for NOACs to be the preferred therapy for stroke prevention. This is now pretty clear. In fact, it includes patients on warfarin, and particularly those with a time in therapeutic range less than 70%. For those, there's now a class 1 recommendation to switch them over to a NOAC. Whereas there's only, in quote unquote, a 2A recommendation to improve the time in therapeutic range. And the reason for that, we just briefly touched on it prior to the rounds today, are twofold. Number one, we know how difficult it is to improve the time in therapeutic range. All of us who have tried to do this, and somebody who you just cannot get into the range knows that. And secondly, there is this misperception or misconception about the target INR, because we feel, this is of course from Elaine Heilig's image, which is now almost 30 years old that she first published this. This is amazing. But we have that feeling that the intracranial bleeding only increases when the INR gets way out of bounds. And same for ischemic stroke on the other side of the spectrum, and that within the target range, people are safe. And that is not correct, because in fact, when we take a look at all events that are happening kind of as the denominator, we find out, and these are data now from the Warfarin arm of the ARISTOTLE trial, we find that for ischemic stroke, but particularly for bleeding complications, actually the vast majority of patients happens while the patients are in the therapeutic range. Last INR values almost unanimously are bang in the center of the therapeutic range. That's particularly true for intracranial bleeding. So for intracranial bleeding, almost 80% of patients actually were in the therapeutic range when it happened. So from a practical point of view, what that means is if you have a patient on warfarin that had today or tomorrow has an INR of 2.5, it does not mean that this patient 10, 14 days down the road will not develop an event. And this is why, one of the reasons why, if they're not well controlled in the first place, it's a class 1 recommendation to switch these patients over to a NOAC. Of course, the question always comes up, does all of this translate into daily clinical care? And we've seen a lot of registry data for dabigatran, rivaroxaban, and apixaban over the last years. If you wanted to summarize them just into one sentence, then it would be that overall, the trial results translate quite well into daily clinical practice. The events that we see there in terms of efficacy and safety pretty much translate quite well into what we see in daily clinical practice. I kind of try to avoid the expression of real world, which is frequently used for observational analyses, because it kind of implies that what we're doing in the randomized trials is somehow not from the real world, but from the moon or from Mars or whatever. But you know, we included a lot of high-risk patients in these randomized clinical trials. This is the gold standard. But of course, we want to see if it translates into daily clinical care. And for the first 3 NOACs, we have clearly seen this. This is the case. Now, for edoxaban, these are comparatively new data. These were published last year, also in the ETNA-EF registry, which is a prospective registry of several thousand patients, actually over 14,000 patients globally. And when we take a look at the outcomes in the observational study, and we compare this to the randomized trial, and this is the way that I feel most comfortable interpreting observational data, to compare this to how it came out in the randomized trial. We also see here that overall the patterns we are observing and the event rates are very much consistent. That's true for the bleeding outcomes as well as for the stroke outcomes. If anything, the absolute event rates are lower than in the ENGAGE-AF trial. Of course, we have to acknowledge that all observational studies have a number of limitations, and one of them is that there may always be incomplete reporting, so we need to take this with a grain of caution. But definitely, as for the 3 other NOACs, also for edoxaban, there is no sign that it's completely off the scale different than what we saw in the randomized trial. Now, moving from here into the elderly patient population, because again, this is a patient population that is at the highest risk for virtually everything. And we frequently feel that we don't have enough data for NOACs available for them. And in fact, we do. This is again now going back to the randomized trials, because the data quality and also the data granularity is just simply the best. And randomized trials are the only source really where we can make a causal claim. So does a drug reduce or increase events, yes or no, on a causal level? And what we saw here was that in younger patients, so less than 75 years, there's a pretty consistent efficacy of NOACs over warfarin. And also in the older patients, 75 years and older, there is a pretty consistent efficacy of NOACs over warfarin. Very consistent, and if anything, even further over in favor of NOACs than in the younger patients. That, of course, doesn't mean that we shouldn't treat younger patients with NOACs, but it just shows that also in the elderly, and particularly in the elderly, we have a benefit, which might even be bigger. So your bang for the buck is even better from an efficacy point of view. But of course, also in these patient populations, we need to take a look at the flip side, major bleeding. What we can see here is that plus minus in the less than 75 years old, there's a pretty consistent safety of NOACs. Rivaroxaban, a little bit of an outlier here, but overall pretty consistent. Whereas for the 75 years and older patients, there's again that same heterogeneity that we observed also in the overall trial results, in the sense that for dabigatran and for rivaroxaban, the point estimate is actually in favor of VKA, although the confidence intervals are overlapping, so there's similar safety formally, statistically. Whereas for edoxaban and apixaban, even in this highest risk patient population, there's better safety. There's actually a reduction in major bleeding as compared to warfarin. And these are 75 years and older patients. We actually also have data for the even older. And just in the ENGAGE-AF trial, over 3,500 patients were 80 years or older at the time of inclusion. And the data were very consistent. In ARISTOTLE, there were almost 2,500 patients 80 years or older. Very consistent. So I think we can say that we actually have data from the ENGAGE-AF trial with edoxaban versus Warfarin. We have more patients 80 years or older than we ever had for vitamin K antagonists versus placebo across the entire spectrum. I think, of course, that's a bit of a stretch because these are from different time periods. ENGAGE was 20 years later, but nevertheless, the evidence base is there even for the oldest type of patients. And yet there are still some questions that are bothering us on in daily clinical practice. And this is why we brought out, we from the European Arrhythmia Association era brought out our practical guide for the use of NOACs. And this is just the latest version that we presented about and published about 6-7 weeks ago or so, and which is available for free for download from the journal's website, where we tackle exactly these issues, including the elderly and including also the concept of frailty. Because again, frailty is age, biological age doesn't necessarily mean is not necessarily the same as chronological age. And I think the concept of frailty is actually quite important. However, frailty frequently, when we see it in a patient or in the list of diagnoses, we kind of view this as black and white. Whereas in fact, there are 50 shades of gray, or actually red, yellow, and green here for frailty, right? There are different degrees of frailty. And correctly so, I think in the most frail patients, we would not anticoagulate them if they have atrial fibrillation just due to the comorbidities. But importantly, in the moderately or specifically in the mildly frail patients, in those patients, it makes sense to think about anticoagulation. And just because they're labeled as frail doesn't mean that they should be excluded from anticoagulation. On the contrary, there are data indicating that these patients benefit even more from being anticoagulated than patients that are not frail, because a stroke in a situation like this is usually a disaster. Well, a stroke is never a good thing, obviously, for anybody, but these patients suffer even more than somebody who is not frail. They will just simply not reach that level again where they came from prior to the stroke, and not infrequently then ultimately end up in a nursing home or dependent on others. We have specifically taken a look at this in the ENGAGE-AF trial, and this is also now 5 years old since we've published this 5 years ago, patients with an increased risk of falling. And I'm saying this because in those over 21,000 patients that we included in ENGAGE, we prospectively identified the ones at an increased risk of falling based on these 8 factors here. And I will just briefly go through this because as you could imagine, those were the sickest of the patients. There were 900 patients that fulfilled the increased risk of falling in this patient population, and they were at an increased risk of almost everything. And after adjustment for the baseline characteristics, still they were at an increased risk of all-cause mortality, as well as bleeding events, and also bone fractures due to fall, which is kind of the internal validation endpoint, if you want. Well, the effect of edoxaban versus warfarin in patients at increased risk of falling is quickly told because there was no statistical interaction. So these patients ultimately benefited the same in terms of efficacy and safety as did those without frailty. But importantly, since they were coming from a higher absolute risk, their absolute risk reduction was even lower. So even more, in the sense that imagine you have a 20% relative risk reduction, both in a low and a high risk population. So indicating no statistical interaction. That means from a practical point of view that both the low and the high risk benefit the same in relative terms. But if you apply this 20% risk reduction to a patient population with a 1% risk, you go from 1 to 0.8. So that's an absolute risk reduction of 0.2% and a number needed to treat of 500. But if you apply that 20%, that same 20% relative risk reduction to a patient population at 10% risk, you come from 10% to 8%. absolute risk reduction 2%, number needed to treat 50. So since the absolute risk and the absolute risk reduction is driving the number needed to treat, your bang for the buck, and this is the key message from this paper, is even bigger in the highest risk patients. So if somebody is at an increased risk of falling, instead of switching that patient over to warfarin, if you keep that patient on edoxaban or put that patient on, in this case, edoxaban, your absolute risk reduction will be even higher than in a patient who is not at an increased risk of falling. There are several other aspects that we're dealing with in this ERA guide, and of course there are far too numerous to cover, also because we also want some time for Q&A today. I just picked out a couple which I felt might be interesting. One of them is extremes of body weights. Now this is something that frequently gives us troubles because we feel that we don't have a lot of data for NOACs. But the good news is that just purely from a body weight perspective, anything between 60 and 120 kilograms is pretty okay. They've been well represented in the trials, and all NOACs can be used just from a body weight perspective at their regular dose. Now, if you go below 60, it becomes a little bit more scarce. It's important to note, though, that for edoxaban, weight less than 60 kilograms was a dose reduction criterion. And for apixaban, it was one of the 3 dose reduction criteria. So if you have less than 60 kilograms and age 80 years or older, or creatinine clearance 1.5 or more, also then you would dose reduce to 2 times 2.5. So probably those 2 in this area might be a preferable choice because they have been tested with dedicated dose reduction criteria. Once you go below 50, certainly once you go below 45, 40, it becomes really, really difficult. And the same is true at the other end of the spectrum, especially once you go over 140 kilograms or a BMI of 50. Now, the problem in this situation is that also for VKA, we don't have all that much outcome data. Of course, again, we can measure the INR, but as we have seen, that doesn't necessarily mean that we're actually providing patients with a net clinical benefit, because the majority of events happens in the therapeutic range. And so this is why we kind of introduce, or well, obviously we weren't the first one to do that, but to bring up this concept of plasma level assessments in these very extreme situations, which of course is an off-label recommendation to take a look at plasma levels, but it may make sense, not necessarily to really guide your therapy according to the levels, but to see if patients are in the range of what is usually expected in the trials, or what was observed in the trials. And I'm again choosing the ENGAGE-AF trial here, obviously, because I had the pleasure and honor of participating in this, but also because as the last of the NOAC trials, and this was this kind of learned a little bit from what had been seen in the other trials, and as a result of that, we took a lot of plasma level measurements in our patients. Now, these were not revealed to the patients or to the investigators, but those were kept for research purposes. So nobody dosed any NOACs according to any levels, but just to see how it comes out. And what was interesting was that in terms of edoxaban concentration and also exogenous anti-10A activity, whether you're in the low body weight, in the high body weight, or in the middle body weight cohort, the plasma levels didn't vary that much, neither for peak nor for trough plasma levels. So that fear that patients who are above 120, 130 kilograms will have plasma levels that are not measurable is probably not justified. But doing this, taking a look at plasma levels likely makes sense, because at least you know that you're kind of in the range of where people would, of where others that were included in the trials found themselves. Now, another thing I would like to briefly touch on is the differences between the NOACs in terms of absorption and metabolism. This is also something we dwell on in our guide. Of course, you've seen these tables a million times already. Just 2 or 3 aspects that I think are important. Bioavailability, keep in mind, pretty low for the bigatran, doesn't have any major implications. Very high with rivaroxaban. Also, that doesn't have major implications, except that we need to remind people to take this with food. If they don't take rivaroxaban with food, they will have about 1/3 less of plasma levels, and hence are less protected against stroke. So very important to remind people of that. Secondly, renal clearance. Big difference, 80% renally clear, the dabigatran, whereas only 27% renally clear, the apixaban. Edoxaban and rivaroxaban, they're somewhere in between. However, edoxaban, the dose of edoxaban is cut in half once people are below 50 creatinine clearance, whereas it is only reduced by 25% for rivaroxaban. And so as a result of all of the trial outcomes, of the subgroup analyses, of the pharmacokinetics and everything, this is kind of our recommendation for the use of NOACs in kidney disease. Patients with CKD, once you're below 50 milliliters per minute, again, I'd be a bit careful with the dabigatran. The dabigatran is a very good drug, as we've seen. It's a very efficacious drug too. But once you go below 50, certainly once you go below 40, there's a certain risk that these patients just drop their renal function without us noticing it, especially now that it gets warm. They may have an infection, they may take some NSAIDs, which of course they shouldn't be in the first place. And then all of a sudden they drop below even further, and then they can accumulate the drug quite easily with the large degree of renal clearance. Whereas 10A inhibitors are allowed all the way down to 15. Now, based on the trial data, based on the pharmacokinetics, the dose reductions, I think we do have good data for, especially for edoxaban and for apixaban, not only, but also in patients with more reduced renal function. So these might be the ones that are best suited in that regard. However, again, acknowledging the fact that there is no head-to-head comparison, and of course, we'd love to see that in order to even make up our mind, better make up our minds. But in the absence of that, we have to make a call also, and hence we came up with this table. The other side of things is frequently a little bit neglected, and that is the metabolism side, because also there are relevant differences. You see for the dabigatran, for example, cytochrome P450 is not at all involved in the metabolism, whereas it is for all other NOACs. For edoxaban, the most important one, the CYP3A4, is only minimally involved. But for the others, they are involved. And this may have important implications. This slide again summarizes the metabolism of all NOACs, kind of giving an idea of how much of it is bioavailable, how much goes to the kidney, how much is metabolized. And the metabolism part is, of course, particularly relevant with respect to dose reductions. And I think here, with co-medications. Very important with respect to co-medications, because this is something that we frequently forget, is that not only vitamin K antagonists have relevant or a potential for drug-drug interactions, but also NOACs do. And in that case, it's one possible way of tackling this is to take a look at these figures in the ERA guide, which continues for another 9 pages or so, to check out whether the drugs that my patient is taking, in addition to that NOAC, may increase or decrease, for that matter, the NOAC's plasma levels. Now, whether you use our ERA guide or whether you use any online database or so to check this, doesn't really matter. The main thing is to check it, especially in those with multiple drug-drug interactions or with multiple co-medications. That doesn't necessarily mean that patients with multiple co-medications should not be treated with NOACs. We've seen this for edoxaban, we've seen this for apixaban, that actually the efficacy and the safety of the NOACs is the same, independent of how many medications these patients are on at baseline. 0 to 3, up to 5 or more, there's no modification. The p-value of interaction is negative. So essentially they all benefit the same. It doesn't mean that we shouldn't be treating these patients with a NOAC, but we should check this in a dedicated fashion in order not to run into any unexpected drug-drug interaction problems. Which then brings me to my summary conclusion. First of all, I think we have seen that AFib is a complex disorder, not only in arrhythmia. Of course, it's also an arrhythmia, but it is a complex disorder in and of itself. From the ESC guidelines, there's the ABC pathway, but also the integrated care and the Canadian guidelines, which we'll hear about in just a second, is essentially talking about exactly the same. Atrial fibrillation needs a team approach in the vast majority of patients, an integrative care pathway. With respect to the anticoagulation part of the ABC pathway, of course, this is the main source, the main means by which we can reduce morbidity and mortality. However, important, we do need to individualize therapy. There is no one-size-fits-all NOAC. It's a complicated area, but I do believe, I strongly believe it is worthwhile investing our time and effort into, as indicated in the beginning, because we're dealing with this in a lot of patients. They will become even more, and we do have a relevant impact on morbidity and mortality. With the ERA guide, I hope we're able to give some guidance for daily clinical practice, particularly, not only, but particularly in situations where we don't have much evidence. And today we have focused a bit on edoxaban. I think what we have seen is that edoxaban does offer, as the last NOAC that became available, a very good safety, but also efficacy profile, especially, not only, but especially in the high-risk populations. And with this, I would like to finish. And I thank you all very much for your attention. Of course, I'm very happy to then tackle any questions. Thank you very much.
Thanks, Professor Steffel. I'm going to present the next half of the talk, and then we'll have questions at the end. Dr. Beanlands, our chair of cardiology, has agreed to moderate the questions. So without much delay, I'll start my presentation, and then at the end of that, we can field questions. Good morning, everybody. As the next stage of this special rounds, I'll take the opportunity to complement Professor Steffel's talk with an updates and changes session on the current Canadian AF guidelines. So these are my honor area and conflicts, but these should not influence the content of this presentation or my talk. I would like to sincerely thank the Canadian Cardiovascular Society, my colleagues in the Arrhythmia Service and Division of Cardiology, for allowing me to serve as a member of the current guidelines. And I would also like to thank Dr. Callum Redpath, my colleague, who's on the secondary panel, for his contribution to the guidelines. So today's objectives are to highlight important changes and modifications in the current iteration of the guidelines. I will talk on specific topics that are very relevant to our audience based on hallway conversations and emails from my colleagues asking me questions about management issues. So I'll be talking about integrated approach to AF management, some salient updates on rate and rhythm control, device-detected AF and exercise, and on LA appendage exclusion excision. This talk cannot be comprehensive and I won't be very granular, but I can always answer questions later. I'll also be taking this opportunity to compare and contrast select differences between the Canadian, European, and American guidelines. So first off, I'd like to say that the grading and of evidence is different between the three guidelines. The European and American guidelines are quite similar in that they use a class 1 to class 3 definition of guidelines. And then for the level of evidence, they use A, B, and C, with the Americans now going on to qualifying whether there's randomized observational studies or just expert consensus. And they've color-coded the strength of recommendations so that it's easy for people to follow. And as you can see, it's quite detailed. So as Canadians, we've taken a different approach. We've used the grade recommendations started by Gordon Guide. And we recognize that most of the end users are not expert cardiologists, electrophysiologists, and need clear direction in most cases. So we have qualified recommendations as strong and weak. We also presented the fact that you can make a strong recommendation with low quality evidence. And we provide clear values and preferences statement to help guide practitioners with practical tips. Evidence is classified as high, where further research is very unlikely to change the estimates of effect. And this could mean that you don't need large randomized trials for some topics. Well-conducted observational trials may be enough. And then moderate, where further research may have an important impact. Low quality of evidence, where further research is unlikely to change the estimate of the effect. And very low, where we have no idea of how effective the treatment or recommendation is. So these differences between methodologies introduce challenges in comparing recommendations across guidelines. While all the guidelines use the same body of literature to come up with recommendations, the way it's interpreted and how it's weighted is different, and that will be highlighted in some of the slides I have. So before going down to the clinical aspects of AF, we have to understand what we aim to do when we diagnose somebody with AF. The first and most important thing is to identify and treat any reversible precipitants. After that, we have three cornerstones for treatment. The first thing is assessment of thromboembolic risk, and we use the CHAD65 score, manage the arrhythmia, and then assessment of risk factors. The Canadian guidelines stress very highly on risk factor modification and oral anticoagulation for patients at risk of stroke. As regards the management of arrhythmia, we'll go into rate and rhythm control, which are the two available strategies. What are the major goals of AF treatment? Is to prevent stroke or systemic embolism and cardiovascular risk reduction. These are so-called hard endpoints, which improve in survival bereft of morbidity. And then we have other softer endpoints like improvement of symptoms, functional capacity, and quality of life, and prevention of complications such as AF-induced LV dysfunction, falls, etc. These improve the patient experience and reduce healthcare utilization by reducing emergency department visits or hospitalizations. Now, there's a lot of research that has been done on understanding atrial fibrillation, and I think it will be unjust not to highlight that, because countless basic scientists have shown us that every episode of AF is just tip of the iceberg. This results from the following. There is a non-modifiable substrate. It's mainly your age, sex, and genetics, which increases as you grow older and has a finite contribution. It's clearly not modifiable. On top of that, you have a modifiable substrate from risk factors for AFib, such as hypertension, obesity, and obstructive sleep apnea. And because of this substrate, we have triggers that spark off AF, which could be inflammation, sympathetic drive, metabolic, or other stressors. And these triggers can contribute to a worsening of the substrate, which is also possibly modifiable. And then when this happens, you have an episode of AF. We identified two kinds: reversible AF, where there is minimal substrate and mostly there is a trigger, which if removed, for example, non-cardiac surgery or cardiac surgery, the patient is unlikely to develop AFib in the long term, most likely. On the other hand, we have provoked AFib, where the substrate is significant and this person is likely to develop atrial fibrillation in future. And this trigger has just unmasked it. And these are the people who are going to develop more and more AF as time goes on. And I think this, a tremendous amount of research has been done, and this is very significant. It has to be highlighted. So we thought it should be presented in the guidelines. Now, the guidelines also recommend opportunistic screening for AF, especially in those greater than 65 years of age, recognizing that occult AF can lead to strokes. There are two kinds of screening that you could use: pulse palpation, blood pressure monitors, and then rhythm-based single lead ECG devices that you can use on your smartphones. If atrial fibrillation is suspected based on these two, we recommend performing an ECG. And if no AF is confirmed, you could go on for additional rhythm-based monitoring if the suspicion is high. And if you have a diagnosis of AF, then you go to the three pillars of management, which is stroke prevention, management of arrhythmia for symptoms and hard outcomes, and assessment of risk factors. The recommendations strongly say that these important risk factors should be addressed: alcohol and tobacco, sleep apnea, weight loss, diabetes, blood pressure, and exercise. And you can read the details on the prescription that we've given based on available evidence. Again, tremendous research in this field has shown us these, has helped us come to these practical targets. So the guidelines also suggest a structured and integrated multidisciplinary patient-focused approach to care. And we feel that an integrated patient-focused team-based approach will improve guideline adherence, reduce adverse clinical outcomes, and improve quality of life. While this is a weak recommendation based on moderate quality evidence, it's nevertheless important enough to be mentioned. And I must say that this diagram captures what an integrated AF clinic does. First of all, for low-risk patients, you can manage them well. Moderate risk patients can be targeted for complex intervention before they become high-risk patients. And high-risk patients that require acute intervention can quickly go to specialist practices for cardiac procedures and specialist consultations. At this point, I would like to thank our UOHI integrated AF clinic, which was mainly started by, with the leadership of Dr. David Burney, and is being ably managed by Meredith. My colleagues, Shelley and Bonnie, were pivotal in a lot of the patient education pieces. I would like to thank my arrhythmia service team members, the pharmacy, smoking cessation, rehab and exercise physiology division, and division of cardiology, and the administration for facilitating our clinic. So with this, I go to the next step, which is acute rate and rhythm control. And the guidelines committee recognized three important questions. What are the rate controlling agents of choice in adults with preserved ejection fraction, those with reduced ejection fraction, and what about rhythm control options? A lot of stuff, especially question number 3, has occurred over the last year, which I'll be highlighting. So I'll give you a general approach to guidelines-based approach to management of rate and rhythm for patients with AF. Now, if you have paroxysmal AF, which typically are intermittent, highly symptomatic, brief episodes, if the burden is low, you can either observe the patient or use pill in the pocket approach. If the patient has high burden with multiple recurrent episodes, you could consider maintenance antiarrhythmic therapy and progress towards catheter ablation if that fails, or based on some recent trials, go directly to catheter ablation. When it comes to persistent AF, which typically represents longer lasting episodes with greater substrate involvement and more risk factors, first thing to do is to initiate rate control and consider long-term treatment. Rhythm control is preferred in individuals with recently diagnosed AF within 1 year, recognizing that if you approach them early, the results are better. Highly symptomatic or significant impairment of lifestyle, multiple recurrences, difficulty to achieve rate control, and if they have arrhythmia-induced cardiomyopathy, we should look at cardioversion followed by definitive treatment for rhythm maintenance in the form of antiarrhythmic therapy or catheter ablation. If the patient can be rate controlled without any symptoms and the patient is not severely affected by this, then we can continue to long-term rate control, though this has been thrown into question in some of the recent trials, which I'll be touching on. If the symptoms persist, you could do cardioversion, and on maintaining sinus rhythm, if symptoms don't improve, then further rhythm control may not be useful. However, if symptoms subsequently improve, then we recommend more definitive treatment strategies. And for this, we are conducting a trial with Dr. Burney and Dr. Sadek trying an intervention here. So when it comes to hemodynamically unstable acute AF, cardiovert immediately. For acute rate control, with people with preserved ejection fraction, we can use beta blockers or calcium channel blockers, and then supplement it with digoxin. If people have LV systolic dysfunction, a beta blocker may be used cautiously if tolerated, but if there is hypotension or decompensation, then amiodarone in combination with digoxin should be used. For acute rhythm control, we go to cardioversion, which I'll be touching up in detail the next slide. So what are goals for long-term rate control? So in those with left ventricular ejection fraction less than 40%, we talked about beta blockers. We can add digoxin. Beta blockers, if they're tolerated without decompensation or hypotension, if not digoxin. And if that fails, consider rhythm control with pacemaker implantation and AV junction ablation. In this subgroup, we strongly recommend considering cardiac resynchronization. In those with ejection fraction greater than 40%, you can use either beta blockers or non-dihydropyridine calcium channel blockers. And if they fail, you can add digoxin. And if that fails, then you can go on to AV node ablation. Remember, there's no amiodarone here, and amiodarone is not a long-term rate control strategy. Now, for cardioversion, where we differ from European guidelines and American guidelines, is that we have said that anybody with valvular AF or non-valvular AF less than 12 hours with recent stroke or TIA, or non-valvular AF with duration between 12 to 48 hours and CHADS-2 score greater than or equal to 2, or duration greater than 48 hours, should have therapeutic anticoagulation for 3 weeks, or alternatively TE to exclude LA thrombus and then cardioversion. And we recommend anticoagulation for 4 weeks post-cardioversion. If the patient is hemodynamically unstable, or if the AF duration is less than 12 hours with no recent stroke or TIA, or between 12 and 48 hours with a CHADS-2 score of 0 to 1, initiate OHI as soon as possible, preferably prior to cardioversion, do the cardioversion, and continue anticoagulation for 4 weeks. And further long-term anticoagulation is based on your CHADS-65 assessment. At this point, I'd like to show some of the differences between the guidelines. Canadian guidelines talk about less than 100. Europeans talk about less than 110. Americans talk about less than 80 and less than 110, which is 2B in their classification. Again, the medications are almost the same. The Europeans caveat say that use calcium blockers in severe COPD or asthma, and do not use calcium blockers in decompensated heart failure. The Canadian guidelines talk about second-line combined digoxin therapy, and also as monotherapy in older or sedentary individuals with permanent AF, contraindication to first-line agents. There are subtle differences, but the principles are almost the same. Then when it comes to cardioversion, both the European and Canadian guidelines use the 12 hours and 12 to 48 hours distinction. The American guidelines, which will soon be updated, I think have not yet used it. The only difference, I think, is we recommend at least 4 weeks, irrespective of what arm the patient falls in. Whereas for the European guidelines, if very low risk, and the American guidelines, very low risk patients, they say that you may not need to cardiovert afterwards. So when it comes to long-term rhythm control, those with heart failure, ejection fraction less than 40%, we use amiodarone. Those greater than 40%, that is HFpEF, amiodarone and sotalol. Those with coronary artery disease, we can use amiodarone or sotalol, and dronedarone is not very preferable, but may be used. We definitely do not use flecainide, propafenone, and sotalol in those with coronary artery disease. And if patients have no heart failure and no CAD, then you can use these 5 medications as treatment agents, with amiodarone being the most effective. When it comes to catheter ablation, all of us know this figure very well. This is a healthy atrium with voltages, all in purple are voltages. And we have recognized from pivotal research from Dr. Isager in France that the pulmonary veins are triggers for AF, triggering AF in paroxysmal and persistent AF. And by isolating the pulmonary veins electrically, we can improve quality of life and reduce AF recurrences. The cornerstone of AF ablation is PVI. Linear lesion sets, cafes, and etc. are not indicated based on some trials. Low voltage areas and other improvements of this are being actively evaluated by our group and Canadian multi-center trials. And the guidelines recommend that the electrophysiologists performing this have high procedural volumes and expertise with at least 20 to 50 procedures per operator per year. Patients, like I said, who are symptomatic after rhythm control may be selected. Select patients with symptomatic AF as first line can be selected. Positive effect on AF burden, symptoms, quality of life, and cardiovascular hospitalizations. Typical atrial flutter, catheter ablation is recommended as first-line treatment, especially because of high success rate, low complication rate, and challenging to achieve pharmacological rate and rhythm control in this subset. A few trials have come out after publication for guidelines. The East AF-NET, which showed early rhythm control is better than rate control in recently diagnosed AF, and the STOP AF and early AF trials, which showed that catheter ablation is superior to antiarrhythmic medications and are likely to be used as first-line therapy in select paroxysmal AF patients. The next goal was to see if catheter ablation would improve hard outcomes such as major adverse cardiac events. And I have to talk about the Cabana trial in a nutshell, which said that the primary outcomes would not improve. However, there was reduction in AF recurrence, and in a per protocol analysis, mortality and secondary analysis show mortality improved. The Castle AF showed reduced hospitalization in those with HFrEF compared to medical therapy. Both these trials have certain limitations which beyond the scope of this talk, and we can discuss later. I have to talk about the Canadian trial RAFT AF, for which Dr. Prakash and Tang led it, and Dr. Bernie and Dr. Neri were important members of this team, which was terminated due to futility concerns. And they looked at hard outcomes like death and heart failure, which is no different in the ablation treatment group arm versus the rate control arm. So this trial compared catheter ablation or rhythm control versus rate control. However, sensitivity analysis showed some borderline significance for those with heart failure, and that event rates were numerically lower in the rhythm control arm. There were also significant improvements noted in significant functional and serum biomarkers, including NT-proBNP. So surgical ablation can be used for concomitant surgical AF ablation and standalone surgical or hybrid ablation, with the understanding that these surgeries may result in repeat ablations or permanent pacing and do not increase or improve hard outcomes. I will leave the device-detected AF and athletic participation for later if somebody has questions. I will stop at this point because we really value questions and we can answer them as you ask questions. So I'm going to stop sharing my presentation and go over to Dr. Rob Beemans, who's going to ask questions. So Kelsey, you can stop sharing your screen.
Thanks very much, Girish, and thanks, Dr. Steffel. Those were great presentations, very informative and helpful for all of us. As you said, there is a pandemic of AF, Dr. Steffel, and I think we face decisions related to this every day. So I really appreciate this informative rounds. So let me just begin by, there's a few questions in the Q&A. And so I'll start with from Joel Nisnik regarding elder care. Can we go lower in elderly patients with bleeding risk factors, i.e. edoxaban 15 milligrams?
That's a very good question indeed. And let me start out by thanking you also for the invitation, for hosting me at your grand rounds today. Really a great pleasure. That's a very good question. The elder care trial is actually one of the few, if not the only trial that actually compared a NOAC to placebo in a certain patient population, right? Because all the others compared to Warfarin, the Averroes compared to aspirin. And what the elder care did was they compared this to octogenarians that were deemed to be unsuitable for anticoagulation, compared a very low dose, 15 milligrams to placebo, and found a relevant risk reduction, over 4.4% absolute risk reduction compared to placebo in terms for stroke and systemic embolism at the cost of a non-significant, about 1.3 or 5 increase in major bleeding. So indicating that in patients that are unsuitable for this or deemed unsuitable, even a very low dose can have a big impact. Now, there are some caveats with this, the most important one, I guess, being that it exclusively included patients from Japan, right? And they do have a different metabolism. They do have different levels also of NOACs. So I don't think we can one-to-one transfer this to the Western Hemisphere. With that being said, though, the ENGAGE-AF trial had a lowered arm of edoxaban, which I didn't talk about at all, but which I'm happy to tackle in the when we meet up then in a couple of minutes with the residents and the fellows, which I'm very happy to tackle there, because there actually we also saw a benefit from a reduced dose of edoxaban in these patients. Now this is fully off-label, but I think this is one of the benefits that we have with edoxaban. It actually has a wealth of data for even lower and reduced doses, and I do believe that there are certain patient profiles that may benefit from this.
All right, thank you very much. And then I guess this would be a question for you, Girish. Comment on the RATE-AF DIG versus bisoprolol trial showing lower adverse events with functional class with DIG. And I guess sort of a related question is, you know, the patients who present acutely with reduced ejection fraction, beta blockers can still be problematic in those patients. So maybe comment on the RATE-AF trial and as well as the guidelines related to beta blockers in patients with reduced ejection fraction presenting acutely.
Right. Yeah. Thanks for the question. Yeah. The guidelines panel, you know, did review the RATE-AF trial, and while the trial had significant methodological challenges, it recognized that digoxin may be useful as an adjunct to beta blockers and calcium blockers in people with normal ejection fraction, and for some elderly individuals who have relative side effects to these medications, digoxin alone may be useful. Digoxin is very poor in controlling rate based on in individuals who are exercising and with high sympathetic drive. So that is one of the challenges. And we have to base our guidelines on the sum of all trials and evidence out there and not just one trial. So I think digoxin has a role. And like you rightly pointed out, in patients with ejection fraction less than 40% or 45% with overt heart failure, calcium channel blockers should not be used. You know, they are really tilts a lot of patients over into overt heart failure. Beta blockers may be used cautiously in a monitored setting in hospital. And if the patient has hypotension or cannot tolerate the medication, then obviously amiodarone and digoxin should be used.
All right, thank you, Girish. Next is from Ian Burwash, and this is actually a question that I think I must ask every month, one of my EP colleagues. What duration of asymptomatic AF captured on a monitor device would you recommend anticoagulation, and in particular in patients older than 65?
Yeah, I have the slide for that. If you're okay, I'll share that.
Sure.
So
recognizing that there's ongoing trials to try.
Right. Yeah. So the diagnosis of AF requires documentation on ECG lasting at least 30 seconds. This is quite conventional and arbitrary. Now, the duration of AF for prescription of OAC is under debate. And this is a summary of all the trials so far. The most trials showed a hazard ratio of 2.9 for subclinical AF detected on devices. They said more than 5 minutes of daily AF burden mattered. The ASSERT trial showed a hazard ratio of 2.5 at 6 minutes, and so on and so forth. The TRENDS trial, which is the latest observational, and then an observational study showed that greater than 24 hours, as the duration increases, it goes up. Now, the reasons for this varied results are because not all episodes of device-detected AF are actually AF and A-flutter. The device labels it wrongly sometimes. Arbitrary time cutoffs not based on any science. These are all secondary analyses. And a lot of the patients are low stroke risk, and you have a heterogeneous population. So based on this, the guidelines say that AF patients greater than 65 years or older with CHADS2 score of greater than 1, or with CHADS score greater than 1, with episodes of subclinical device-detected AF greater than 24 continuous hours, we would recommend OAC. And understanding that the association between duration of device detected and the risk of stroke is present even in the absence of clinical AF, and that we can always consider it in select high-risk patients with shorter lasting episodes. 3 ongoing trials are, answering this question. Artesia led by Healy and Burney, Ocean and NOAC. And once we have these results, we'll know more.
So 24 hours, that would be on device interrogation? Or
Yes, on device like a pacemaker or
right.
ICD or a loop recorder.
Or Holter monitor.
So Holter monitor will be considered an ECG recording and clinical. These are device detected, subclinical AF. So my point is, if somebody has AF on a Holter because of palpitations, and the Holter is a 3-lead ECG, we are not talking about that individual. We're not talking about the individual with an ICD who has obvious clinical AF documented on ECG and is presenting to you. We're talking about a patient who has no symptoms, does not know he or she has AFib, comes into the device clinic, and our device clinic nurse checks the device and sees there's 24 hours of AF, which the patient may be mildly symptomatic and does not know, and has not been caught on an ECG, because the only tracing we have is an intracardiac electrogram. We're talking about that group of patients. All right.
Our time is just past 8:30. This has been, let me just see this. Well, we do have a couple of outstanding questions here. I think what we'll do in the interest of time is basically we could forward these questions to both of you. And seek your advice and input. If there's time, we could stay on if you're available to ask these other questions briefly. Girish, what would you like to do?
Professor Steffel is available. I think we should address questions directed to him first. I'm always available here, but I'm okay to stay and
okay, so we'll cover these quickly here. Should we regularly repeat plasma levels on high BMI patients on DOACs?
That's a very good question. But if you allow me to, I will briefly share my screen here just to show what the European guidelines say on the previous topic, because I think it is a very important one. And the point that Dr. Nair was mentioning at the very end, I think, was also absolutely crucial. It's something completely different if somebody comes in, has a Holter monitor and said, yes, yesterday at 4 p.m. I again had what I always had. And you see a fib, because then you've diagnosed the thing, no matter how long it is, right? The conventional cutoff in Holter is 30 seconds, and then you've diagnosed the disease. That's, by the way, also true with smartwatches or with other devices where you can diagnose with an ECG, the AliveCore, for example, that you give to patients and they say, yes, doc, now I had it, and look, this is what I recorded. This is not what's meant with device-detected AF. The device-detected AF is more in patients that are completely asymptomatic, that come in, you ask them, well, what happened last week? And they say, well, nothing happened. I felt completely normal. And you realize that they have these atrial high rate episodes. This is what this is all about. And obviously the European guidelines have exactly the same basis of data as Dr. Nair was elegantly alluding to earlier, but sometimes they make a little bit different recommendations of them. And they kind of give this a bit of a graded type of recommendation in the sense that, yes, in those where you have atrial high rate episodes or subclinical atrial fibrillation of 24 hours or more, this is where the burden is high enough, especially in CHA2DS2-VASc of 2 in men, 3 in women, to start anticoagulation. And if you're in a very low risk situation, then yes, we would not start anticoagulation. And for the in-betweens, this is where really clinical judgment then comes into play. And this is obviously where we're waiting Artesia, NOAC, the Ocean trial to guide us further. But I just wanted to briefly make that point again about because that is a very constant, especially now in the era of smartwatches and everything, a very constant and important source of confusion that we're observing a lot.
All right, thanks, Dr. Steffel. I'm gonna ask you to sign off because it's the Meet the Masters time, and I don't want to delay that time with the residents any longer.
Okay.
But Girish, there is one other important question here. I'm just gonna, if we can stay on. that is really regarding left atrial appendage occlusion in patients contraindicated for oral anticoagulation. Can you comment on what the guidelines say about that? And I'll let Dr. Steffel sign off, and thank you so much for coming. It was a great presentation.
Thank you. The pleasure was all mine.
Yeah.
Thank you very much indeed.
Okay.
Thanks, Rob. So the guidelines were written before the Laos trial came out from NEJM. So what you can see in the Canadian guidelines is it can be considered for people with absolute contraindications to OAC, whereas European and American guidelines say contraindication to long-term anticoagulation. For surgical LAO occlusion, concomitant surgical LAO can be considered in people who are undergoing open chest cardiac surgical procedures ineligible for long-term OAC, or a surgical LA appendage occlusion or excision in patients at moderate to high risk strokes with contraindications to OAC and not suitable for percutaneous LAO. Now, these are all weak recommendations based on low quality evidence. The LAOS trial, as you know, looked at surgical exclusion, excision on top of anticoagulation. So it's not instead of anticoagulation. And actually, Jan Steffel had, met with us before this and had a very sensible answer to this question. And I wish he were also there to answer it. But this is what the guidelines say. The ESC guidelines and the American guidelines are less nuanced than the Canadian guidelines. I think the Canadian guidelines are a little more conservative than the American and European guidelines. And he was suggesting that a lot of non-guideline device closures are going on in Europe, and they are having a challenge there. Okay,
this has been excellent. There is one more question from Willie. Maybe it's an important one. It's the question about the monitoring of Holters after non-arrhythmic symptoms. So what amount of AF on a Holter that's done for non-arrhythmic symptoms?
A Holter, again, Holter is considered an ECG and 30 seconds or more.
How many?
30 seconds.
13 seconds of AF?
30 seconds.
30 seconds, yes. And that would be enough to warrant anticoagulation?
Depending on your CHAT 65 score.
Yeah, gotcha. Excellent. This has been awesome, Girish. I apologize we went over, but it shows you the engagement and importance of the question, and appreciate your time. And Dr. Steffel, I know you'll pass on our thanks to him for a great rounds. Awesome. Good stuff.
Thanks.
Have a great day, everyone.